Now, with all those treatments available, people with diabetes really have no barriers to do whatever job they want to, for example, climb Mount Everest. They can do anything.
Welcome to another episode of the HSE Talking Health and Wellbeing podcast. My name is Eamon Keogh. On this episode, we'll be discussing diabetes, which is a lifelong condition requiring careful self-management. We'll be talking about the different types of diabetes and also the supports available to people living with diabetes. Joining me to talk through all this and more are Dr. Kate Gajewska, Clinical Manager for Advocacy and Research Diabetes Ireland, and Dr. Cathy Breen, Interim Dietetic Lead, HSE National Clinical Programme for Diabetes. You're both very welcome to our podcast.
Thanks very much for having us on, Eamon.
Not at all. Kate, maybe you could start by telling us more about what diabetes is.
What diabetes is. So from a very basic perspective, it's a chronic condition in which body doesn't properly process food for energy. And it is characterized by chronic hyperglycemia, meaning that the glucose levels are high and elevated. And there are different types of diabetes. Diabetes is one of the most prevalent and dangerous conditions worldwide. That's from the very basic point of view.
Yeah, and is it very prevalent in Ireland?
Yes, we estimate, but unfortunately we don't have diabetes registry. We don't have accurate numbers, but we estimate that approximately 300,000 people will be living with diabetes in Ireland. And it is the most prevalent chronic condition in people between age 45 to 75.
Okay, so you can develop it over time.
Yes, absolutely.
Yeah. Okay. And is it hereditary as well, or how do people develop diabetes?
There are different types of diabetes, and that's why there will be a different genetic factors. But for type 2 diabetes, there is a strong association with having diabetes in your family, especially in your closest family. There are risk factors associated with type 2 diabetes, but type 1 diabetes is an autoimmune condition. And it works a bit differently. So there will be many people who are diagnosed with type 1 diabetes with nobody in their family having diabetes at all. So it depends on the type.
Okay, so just since you mentioned the types there, maybe if you would mind just explaining what type 1 diabetes is.
Yes, so type 1 diabetes is, as I mentioned earlier, autoimmune condition. It develops when a body starts to attack the healthy cells which are producing insulin in the pancreas. So the effect is that the pancreas doesn't produce insulin or produce very, very low amounts of insulin, whereas insulin is absolutely essential hormone to live. And that's why, since a person is diagnosed with type 1 diabetes, she or he needs to take insulin straight away and take it until the end of their lives.
Okay. And Cathy, maybe if I could just ask you about type 2 diabetes and what the difference is there.
Yeah, there's some similarities with type 1 diabetes that Kate has talked about, in that it's characterized by high blood glucose levels in the body. There is a genetic aspect to it as well. So if you have a family history of type 2 diabetes, you're more at risk of developing it.
Right.
But unlike type 1 diabetes, it's not autoimmune. The risk factors for developing it are probably more to do with some health behaviors, so lack of activity, nutrition, but also things like aging and ethnicity. So some of those factors, I suppose, the way we differentiate type 2 and type 1, some of the risk factors for type 2 diabetes are what we consider modifiable. So things like activity and nutrition in some cases.
And you mentioned age there. So is there a particular age where somebody is more at risk, or an age cohort?
That's an interesting one. I suppose we used to think historically that type 2 diabetes was something people developed when they were older. So as we get older and age, we're more at risk of developing it. But actually, some of the statistics are showing now that people are developing type 2 diabetes at a younger age. And that's probably because on a population basis, weight is higher. It's more challenging for us all to live a healthier lifestyle. So you can develop it really at any age in adulthood, but more likely as we get older.
And Kate, what other types of diabetes are there?
Yeah, so we mentioned type 2 diabetes, which is the most prevalent one, and approximately 90% of cases would be people with type 2 diabetes. Approximately 9-10 would be people with type 1 diabetes. But then we also have gestational diabetes that occurs during pregnancy.
Right.
There are also other subtypes, MODY, LADA. They have very different genetic background, but we all call them diabetes because the symptom is the same, so elevated glucose levels.
Okay. And where can people get more information about the different types of diabetes that you mentioned there, just if people want to investigate it a bit more or learn more about it?
So there will be definitely a lot of information on our Diabetes Island website, www.diabetes.ie, and on the HSE website.
Yeah, absolutely. So www.hse.ie/diabetes will have all of that information.
Okay, very good. Another term that I saw in reading up about this before we came on today is pre-diabetes. Maybe you could explain a little bit about that, Cathy.
Yeah, absolutely. So pre-diabetes, I suppose, is where the blood glucose levels are higher than the healthy range, but not high enough for a diagnosis of type 2 diabetes. And it puts you at risk of developing type 2 diabetes in the future. But the good news is that the risk can be reduced with type 2 diabetes. So it's one of these things that doesn't have to turn into type 2 diabetes with the right support and treatment. Again, there'll be some risk factors for it that are modifiable and some that aren't. So again, overweight, aging, ethnicity, these are all risk factors for pre-diabetes, but also activity and nutrition.
Okay. And if somebody feels that they're tired or I know there's other symptoms as well, but should they go and see a GP? What's the best thing to do?
Absolutely. Yeah. I think we'd always advise going to see your GP if you have any symptoms at all of diabetes. I think one of the things to be aware of is that pre-diabetes, you may not have any symptoms.
Really? Yeah.
So it can be, I suppose, a silent disease in some ways.
Yeah.
So one of the advances in the HSE in the last few years as part of our integrated care program is a screening program for pre-diabetes. And if people are identified as at risk and having pre-diabetes, you can be referred to a treatment program now called the Diabetes Prevention Program.
Right.
And that would be via your GP.
Very good. And just as we're talking about symptoms, Kate, maybe if we could just talk about the type 1 symptoms for a minute.
Yes, absolutely. Type 1 diabetes would be a lot more severe when it comes to symptoms, but it can also be hard to spot. That's why it is extremely important to know and be aware of very typical symptoms of type 1 diabetes and actually insulin deficiency. Because if you have no insulin, this is when all those symptoms appear. And among the symptoms, it's increased thirst. So people are very, very thirsty. Energy is being reduced. So we are tired. We are very often exhausted. We observe sudden weight loss or weight change, but usually it's weight loss. So people are losing weight and frequently they need to go to the toilet because they need to urine more frequently. So in Diabetes Island, together with Irish Childhood Diabetes Register, we developed a test campaign. And TEST is actually the acronym for all those symptoms. So T like thirst increased, E like energy reduced, S like sudden weight loss, and T as toilet trips frequently.
Okay, so for any parent who is worried listening, who might suspect or be concerned about their child, the test really is
Yes, absolutely. It's not only for the parents. I think it's very important to mention that type 1 diabetes is not only diagnosed in children, although historically we called it juvenile diabetes. There will be more diagnosis of type 1 diabetes in adults than in children in Ireland and worldwide. And type 1 diabetes can be diagnosed at any age. You can be 50, you can be 60, 70, 40, but of course it is most often recognized in children. So actually the whole population should be aware of the symptoms. Teachers at school, colleagues at work, and of course ourselves and all the healthcare workers, because sometimes a healthcare worker can spot the symptoms and combine the dots. And it's very easy to diagnose diabetes. It only requires a test of urine sample or even random finger prick test can tell us whether we should be diagnosed further or not.
That's a really good point. Thank you. And Cathy, maybe if I could just focus on the symptoms for type 2 diabetes.
Yeah, they're similar for some people. The symptoms that Kate has described, that thirst and peeing more and feeling tired or weight loss, they happen when the blood glucose levels are higher than the healthy range. That's the body's response or way of trying to manage that. One of the things I suppose with type 2 diabetes is that you can have a range of blood glucose levels. So they'll be higher than the healthy range, but they're not always high enough to have those overt symptoms that Kate has described in type 1 diabetes. You can have a spectrum of symptoms, I suppose, with type 2 diabetes. And that's again why we would say if you have any symptom, you certainly should attend your GP to have that investigated further.
Okay.
As Cathy mentioned earlier, I think it's important to know that many people would be living with diabetes and not knowing about it because it's undiagnosed. And it can be undiagnosed for ages, which is very, very dangerous because if we don't know that we have diabetes, it can affect our organs, our risk of complications. And unfortunately, it sometimes happens that diabetes is being diagnosed, for example, when a cardiac event occurs. So it's really important to diagnose diabetes early, to be aware of the symptoms. And I just wanted to add as well that especially in pediatric population or in people who might potentially have type 1 diabetes, it is very important to diagnose it early and react quicker sooner than later, because if we won't react quickly, there is a risk of developing diabetes ketoacidosis, which is an effect of the lack of insulin. And it can be a fatal and very dangerous condition. And it can be all prevented with early diagnosis. Unfortunately, in Ireland, the percentage of DKA at the time of diagnosis of diabetes is 40%, which is very high compared to other European countries. That's why I think it's worthwhile to really mention and advocate and promote awareness of symptoms of diabetes. So if anything, please remember those.
Okay. If you suspect it all, go and seek that test. And it sounds like it's a very simple test as well.
Yes. And also it's important to know that if you diagnose type 2 diabetes, you can still be treated in the community care with GPs. You do not require urgent reaction. Whereas if you're diagnosed with type 1 diabetes, you should be admitted to the emergency department and in the hospital care to receive insulin treatment as soon as possible.
So the treatment for type 1 is going to the hospital and insulin care, as you said?
Absolutely. Treatment of type 1 diabetes is within hospital diabetes teams, both in pediatric and adult care. The insulin has to be started straight away, and then it just depends on what type of treatment, of insulin treatment and therapy will be provided.
So you mentioned insulin as a treatment for type 1 diabetes. Are there other treatments as well?
Insulin is a necessity, but there are different types of insulin.
Right.
But what people with type 1 diabetes would have to do is to inject insulin daily, a couple of times a day. Insulin is required for the body to work at all. We call it basal insulin or basal dosing of insulin. And then whenever we eat, we need to deliver insulin pre-meal. So it's a lot of injections. It's a lot of insulin delivery included. And of course, there is a continuous glucose monitoring. So we have to check glucose levels all day, every day. There's no break from that because we need to know whether we are safe with our insulin treatment and management. The technology in the last couple of years developed extremely fast, and we have now fantastic tools to deliver insulin. We have insulin pumps. We can deliver insulin via injections, as I mentioned, but we have insulin pumps as well, which deliver insulin via infusion sets and require clicking a few buttons to deliver insulin. And we also have automated insulin delivery systems, closed loop systems, or artificial pancreas systems. There are 3 names for the same thing. But these devices interpret information from continuous glucose monitoring, and based on this information, with the special algorithm, they deliver insulin automatically. So if we have such a tool, it really takes a lot of burden when it comes to managing diabetes.
Okay. And does everybody have access to those tools?
Well, access is unfortunately an issue. I would say that the vast majority of people with type 1 diabetes would be still delivering insulin via injections.
Yeah.
In pediatric population, more than half of children would be on insulin pumps or automated insulin delivery systems. But for adults, it will be maybe between 10 and 20%. What is also, I think, important to note is that all people with type 1 diabetes are now eligible to use continuous glucose monitoring. And before that, so it's only the last year really, people had to finger prick. And continuous glucose monitoring is probably one of the biggest advances in diabetes care recently. So now all people with type 1 diabetes should be using those. But we don't know what the uptake is. We really don't know the numbers. We don't have registries and audits to prove that.
And if I could come in there, Kate, the other thing that has really, I suppose, increased is access to a structured diabetes support program called DAFNE, which stands for Dose Adjusted for Normal Eating. So it provides kind of skill-based training for adults with type 1 diabetes to develop autonomy and competence and confidence in their diabetes self-management. So adjusting their insulin, estimating carbohydrate, and really getting the best out of that data they're seeing coming through from their CGMs.
Okay.
We've had real expansion with HSE investment in the last few years. So we went from only 6 sites delivering DAFNE in 2016 to now 22 sites across the country. So anyone with type 1 diabetes will be attending hospital-based diabetes service. So we would advise people to check in with their own diabetes service as to when it's available and where it's available. And at different sites offer it differently. In some cases, it's a face-to-face course, and in others, it's remote, or there's sometimes a blend of both.
Yeah. Okay. Maybe if we move on to type 2 diabetes now and just the treatment.
Yeah, Kate mentioned that type 1 diabetes always needs insulin. Yeah. But in type 2 diabetes, some people do go on to need insulin. But for the majority, and usually at the beginning of diagnosis, it's more medications, oral medications, and lifestyle changes. So health behaviors. So again, nutrition, activity, sleep, stress. So managing all of those things. One thing to highlight with treatment in Ireland in the last couple of years, so historically, all diabetes treatment was delivered in hospitals, but we're really trying to move type 2 diabetes care in line with Sláinte care into the community. And there's been significant investment in a program called CDM, or chronic disease management,
right? Which
now means if you have type 2 diabetes, there's a good chance that you can attend your GP through this chronic disease management program. The majority of GPs have signed up for it. So you do need a medical card or GP visit card.
Yeah.
They are entitled to be seen by GP and practice nurse twice a year for medical review of your diabetes and putting together a care plan for your diabetes that suits you, an individualized care plan. And then we've also had investment in 30 community-based hubs around the country who now have specialist diabetes teams. So instead of having to always go to the hospital to see your diabetes team, you may be able to access that closer to home in the community.
Very good. We've talked a lot about the treatments and the symptoms. I wanted to ask you about what does it mean for people living with diabetes on a daily basis. I mentioned in my intro there that it's about self-management. I mean, there's a lot of personal self-management required, isn't there, for both types?
Yes, absolutely. I think diabetes is one and only condition that requires so much input from the person living with condition, because it's not only taking pill once a day or twice a day. It's every decision is being guided by the fact that you have diabetes and the fact that you have to control your glucose levels. People with type 1 diabetes have to continuously check their glucose levels. They have to know what is happening, whether they are safe, whether their sugar levels are not going too low, and they don't have hypoglycemia, because if they have hypoglycemia, they feel really unwell and it's dangerous. So they have to eat something and increase the glucose levels. They also have to control the risk of hyperglycemia. So if the sugar levels are not too high, and if they are, they need to adjust insulin. There are more than 40 factors affecting blood glucose levels. So it's not only food and it's not only insulin. There's also temperature, hormones, puberty. Everything can affect glucose levels. So that's why it can be very, very burdensome for many. It may be especially in the beginning when you're diagnosed and you have to learn all this diabetes self-management aspect. You have to get your diabetes education, whether it's individual, face-to-face, or online education, or whether it's a structured education program like DAFNE. You have to take insulin. You have to control whether you're safe. And just consider every decision that you make from the perspective of diabetes.
Yeah. And of course, you're talking from personal experience as well.
Yes, absolutely.
That's your daily journey as well. Yeah.
Yes, I have type 1 diabetes myself. I was diagnosed as a very little child when I was 1.5 years old.
Yeah.
And I went through very different treatments and types of management of diabetes. I think that technology is absolutely fantastic because it really improves not only diabetes outcomes such as glucose levels or diabetes management control, it hugely improves the quality of life, the opportunities, the options. And now with all those treatments available, people with diabetes really have no barriers to do whatever job they want to, for example, climb Mount Everest. They can do anything. It just requires a lot of work. And it also has to be mentioned that it continuously requires effort from people living with condition and of course their carers, families, and their diabetes teams.
Yeah. And it's important to engage with your GP and really understand it. And there's a lot of support, as we talked about, on the Diabetes Ireland website and the HSE website as well.
Absolutely. And, I think it's recognising that diabetes is a serious but treatable condition.
Yeah.
And our role as healthcare professionals is to support and empower people and to be hopeful that they can manage it and manage it in their lives and live well with diabetes. And that looks different for everyone. What you need to do to manage it is different. I think in type 2 diabetes world, one of our recommendations always, certainly on diagnosis and at other points in your life with diabetes, is referral to a diabetes structured education program for type 2 diabetes. And again, the HSE provides a number of these courses. Discover Diabetes is a common one, or Desmond in other parts of the country. And those courses provide people with lots of up-to-date information on managing type 2 diabetes. They're group-based, so you share experiences with other people and get some peer support from other people who are trying to manage this very burdensome condition.
Yeah.
They're really high quality as well, developed and delivered by trained healthcare professionals and accredited, and really give you an opportunity to develop your own care plan for how best to manage your diabetes. And they work very well in conjunction with that CDM program that I mentioned earlier.
Yeah, very good.
If I could add something, Cathy mentioned that the CDM program is for people with medical cards and GP visit cards, which means that actually approximately 40% of people living with type 2 diabetes won't have access to that, unfortunately, other than paying privately. That's why I would also like to mention that in Diabetes Ireland, we provide a code structured education program, which is very similar to Desmond or Discover. It is accessible for anyone. It's online group education, and it is free for everyone. So please just check Diabetes Ireland if interested.
And I should probably mention that while CDM is based on medical card, our GP visit card access, actually referral into those hubs and the specialist teams in the community, or referral to any of those structured education programs, is completely free of charge for everybody. So regardless of whether you have medical card or not.
Yeah, it's free of charge.
It's free of charge, yeah.
Okay.
And again, you'll get that information at hse.ie/diabetes.
Okay. Thank you. We've talked about the physical aspects of living with diabetes, but I just wanted to focus on the stigma associated with diabetes, or if there is stigma, or you feel there is still stigma associated with diabetes.
Yes, absolutely. I don't know any person with diabetes who hasn't been asked, oh, you ate too much sugar. It's always like that. Even children are being suggested that they've done something wrong and that's why they cause diabetes. Whereas nobody, whether it's a person with type 1 diabetes or type 2 diabetes or any other type, nobody asks for it. The stigma comes back to the lack of awareness of people, of the public, and all this kind of judgmental pictures or imaginations that we see when we think of a person with diabetes. We have this kind of stereotype in our mind. And definitely there is a lot of judgment. There is also a lot of judgment among healthcare professionals, unfortunately, that you did it to yourself. You didn't live healthy enough. And that's your fault that you got it. That's why the language, the stigmatization is something that we really strongly advocate to reduce. And I think this kind of podcast is also a great opportunity to talk about it. And Cathy was heavily involved in developing a Language Matters document. So maybe you'd like to follow up on that.
It's been a lovely collaboration, I think, between HSE and Diabetes Ireland, hasn't it? So Language Matters is an international movement around the language that we use when we're talking about diabetes and other chronic conditions, and just recognizing that the words we use, they can help or they can hinder.
Yeah.
And we developed a guide for media last year, which is available on the Diabetes Ireland website, giving some suggestions for more helpful words people can use. So one example is that concept of person-first language. So we've tried to move away from the term diabetic or any of these ideas about shame and blame, and using more helpful language. So I'm a person with diabetes, and recognizing, as Kate said, that there's a genetic underpinning to a lot of things in diabetes, and that people are doing their best to manage this condition. So it's a really helpful resource, and we're working on a specific resource for healthcare professionals at the moment as well on a parallel project.
Yeah, very good. Interestingly, I hear it time and time again on the different episodes I've done around different long-term illnesses and chronic diseases that language really matters and it can make such a difference. And I know healthcare professionals are really busy and they're doing their best But even just, I suppose, considering that a little bit more and just, as you say, thinking about the language you're using in a way that's non-judgmental and that empathetic voice, really, isn't it?
I think there's a bit of a fallacy out there with some healthcare professionals that they feel it helps to call it out or be harsh with somebody.
Yeah.
But actually, all the evidence that we have shows the opposite, that when people feel shamed or blamed about their health condition, they're less likely to engage in meaningful ways to manage it.
Yeah.
So we're doing harm, not helping when we take that approach.
I mean, I've heard from previous guests that you nearly disengage with the health service because if you get a really bad experience, you step away for a while. Based on what you were saying there, Kate, just about the time element and the important to be diagnosed and to be treated. So that's valuable time. Maybe if someone had a bad experience that they've lost in terms of how they then go forward and manage their
Oh, absolutely. And I think it's extremely important to realize that this is a lifelong condition. It doesn't disappear. It doesn't go nowhere. And that's why it's also important to figure out as a healthcare professional that people with diabetes, whether it's type 1 or whether it's type 2, they live with this condition daily. The 99.999% of the work around diabetes is their own work and their own self-management. Whereas seeing a healthcare professional team happens every couple of times a year, maybe, if it's good care provided. It often happens, unfortunately, that, for example, a person has only one appointment a year or is being seen by the diabetes team once a year, maybe twice. So it's a really time that needs to be used well as a healthcare professional. And if there is something wrong and if there is judgment and if there is this rushed conversation, the risk that that person with diabetes will really disengage is quite high because I'm doing it myself anyways. So why would I bother even talking to someone who will judge me now? That's, I think, very important. And the language, the way how we think of people with diabetes is also a huge contributor to the overall burden of living with diabetes and diabetes distress. Very often contacts with healthcare providers are listed as something very distressing. And diabetes distress is common in people with type 1, type 2 diabetes, any type really, in parents and carers of children with diabetes. Anyone can experience diabetes distress because it's really, really difficult condition to live with. It really requires so much effort and the expectations are always very high from everyone. And ongoing risk that you can just ask Dr. Google and you'll see all those complications that are very scary. It all contribute to additional risks related to mental health. And people with diabetes, whether it's type 1 or type 2, are at much higher risk of developing, for example, depression or anxiety than their peers without diabetes.
Yeah. Okay. I suppose it's worth saying as well, that's why as well, if you're looking for more information, go to trusted sources, because I'm conscious there's a lot of misinformation out there, I'm sure, as well.
Absolutely. Yeah. I think if you Google diabetes, that's probably not a helpful approach. There's a lot of information out there. So yeah, absolutely. Go to see website or diabetes.ie.
So I'm just thinking of different environmental factors that present a challenge for people. I know we talked about segments of the population being more prone to diabetes and, your age and things like that. But I suppose I'm particularly conscious of the food environment around us at the moment and the high sugar, high processed foods in particular that are being aggressively pushed at us.
Yeah. Coming back to Kate's earlier point, I think it is important to say you can't give yourself diabetes.
Yeah.
So even though, the environment we're in can absolutely make diabetes more challenging to manage, eating too much sugar does not give anybody diabetes. I think we do want to be clear on that today. I think the food environment we live in 2024 is very challenging. We'd often use the term health disrupting for all of us, no matter what health condition we live with. And I suppose we are looking for broader or governmental policies that make the healthier choice the easier choice on a really broad level. And everyone is trying to make the best choice they can given their own circumstances. I think an important point to highlight is the socioeconomic gradient as well. So we know that where you live and your educational background and the job you have, they all determine your access to being able to live a healthier lifestyle and can definitely make it more difficult. I think on an individual level, speaking as a dietitian, we'll always talk with people one-to-one about trying to plan ahead, because the reality is the food environment we're in makes it really challenging to eat healthily as part of a diabetes treatment plan or any other treatment plan. Planning ahead with food, I think, sometimes reduces the chance of when we're out and about in shops or in restaurants. You're right, we are surrounded, I suppose, by quick, easy, typically less healthy foods.
Yeah.
Usually this easy, unhealthy food is usually cheaper than the
point.
food that you have to prepare yourself. It's preparing yourself, your own meals requires time, requires effort, thinking through, and it requires money. So from that point of view, as Cathy mentioned, we really live in a very challenging environment when it comes to nutrition.
Yeah. And I know Safe Food have an ongoing campaign on that, trying to change the narrative on that. So hopefully we'll see more on that.
I suppose it's changing the narrative at an individual level, but also needing probably cross-governmental policies around poverty and food environment. And it's broader than the person that's sitting in front of you with diabetes.
Yeah. And education, starting even from primary schools, like healthy eating policies, etc. It all helps.
And Kate, just to talk a little bit now about the work that Diabetes Ireland do. I mean, we've mentioned the resources on your website and that, but would you like to just give us a small insight into other work you're doing?
Yes, absolutely. Diabetes Ireland is a charity. We work together with healthcare professionals, but we are there for the people living with diabetes and their closest ones. And as part of our overall aims and roles, it's to support people with diabetes. So, for example, my role as a clinical manager for Advocacy and Research, my role would be in advocacy. I would be working to improve access to, for example, technology, access to care, to highlight the gaps, to help developing guidelines, to help developing standards of care, etc., and advocate for better care and better quality of life for people with diabetes. As part of my research role, I'll be supporting research. So all the research ongoing in Ireland would probably be somehow supported by us from many different angles. But we also do a lot of education. We have a SMART program, which is online education program about type 2 diabetes. We have a code, which I mentioned earlier, which is a structured education program delivered by our nurses and dietitians in Diabetes Ireland. We currently develop a Wellbeing support program for people with type 2 diabetes. We are actually at the piloting stage now. We also develop programs for parents of children with diabetes. We have a family program. We develop programs for type 1, for people with type 1 diabetes, to support their way since diagnosis of diabetes. We also provide awareness campaigns like tests mentioned earlier, but also about the complications, about screening for complications. We are always there when there are any media queries. So yeah, we have a very small team, but we are very, very busy here in Ireland.
And the website is diabetes.ie, isn't that right?
Yes, indeed. We also have email address info@diabetes.ie. We also have our helpline number, and we receive many calls from people living with diabetes or those who think that might be at risk. We receive many calls from healthcare professionals, from nurses, from GPs, from doctors. So anyone who has any question related to diabetes, please do get in touch. We have information leaflets. We have booklets for people with type 2 diabetes. So please do see website and find all our contact details.
And what is the helpline number?
It's 01-842 8118.
That's great.
Yes. And just to mention, the more member we have, the more people support us, the more things we can do, because we also, of course, organize events. We organize conferences for people with diabetes, for healthcare professionals, the biggest diabetes-specific conference. We support Diabetes Technology Network Ireland. So yeah, we are working on all the angles when it comes to diabetes care.
Very good. And Cathy, just from a HSE perspective, are there any other supports that you want to mention?
Yes, the other one I think worth mentioning is the HSE My Diabetes email program, which is a 12-month email support program where a person will receive an email every 1 to 2 weeks when they sign up. And in those emails, the person will get advice and support about common treatments for type 2 diabetes, healthy eating, mental health, and much more. And again, you can sign up at hse.ie/mydiabetes.
Okay, thank you. And finally, are there any developments or new initiatives coming down the tracks you'd like to share before we finish? And Cathy, I might start with you.
For the HSE, in relation to type 2 diabetes, the most significant change, and this is all recent, has been that chronic disease management programme, that shift with type 2 diabetes to offer more care locally, and the specialist diabetes teams in the hubs, and access to structured self-management education programs and diabetes support courses. So there's been huge investment in that in the HSE in the last number of years. And fundamentally, the aim of that is to reduce the progression of complications with diabetes. And we're already seeing really positive results actually from that, and people improving diabetes outcomes such as HbA1c, which you've mentioned already, and weight. Type 1 diabetes, there's been vast improvement in access to Daphne and also diabetes technology. And again, bringing us probably up to line with international standards for type 1 diabetes care. And very broadly, I suppose, at a policy level, one of the things that has been challenging, I think, for us is the lack of a diabetes registry. But that is going to move ahead in the next year or so. So that's going to be really helpful, I think, on a policy level.
Yeah, that's great. That's progressing, is it?
That's progressing, yeah, absolutely. And that will give us, I suppose, a really sound basis from which to generate information on the numbers of people with diabetes and hopefully outcomes and treatments as well.
Okay, very good. And Kate, if I could turn to you maybe just finally again, and you've given us a great summary of what Diabetes Ireland are doing, but in terms of yourself, are there any new initiatives that you're particularly excited about?
Yes, from the policy perspective, we're thrilled that after more than 20 years, the Department of Health recognized the need for some improvements in diabetes care. So since July, we work on the Diabetes Policy and Services Review together with the Department of Health and the National Clinical Programme. It's a multidisciplinary, multi-key stakeholder group which aims to highlight the current and existing gaps, which we all know about, unfortunately exist, and try to prepare a plan and the strategy to tackle those issues. We're very thrilled that this need has been recognized by the Department of Health, and we hope that the work will be ongoing, that the funding will be provided, because nothing happens without the funding, and that those needs that people with diabetes have in Ireland will be finally met, because we know what we should be doing. We have fantastic guidelines. We have very motivated and dedicated healthcare professionals, researchers, people living with condition, advocates. But unfortunately, many people do not receive care that they deserve. There is a postcode lottery, especially when it comes to accessing technology, especially when it comes to accessing multidisciplinary expert diabetes support. Yeah, there's also a gap, as Cathy mentioned, related to data. So diabetes registry, clinical audits, that's a big gap, and very low involvement of dedicated psychologists in multidisciplinary diabetes teams and in community care. So we do hope that all these gaps will be officially recognized and will be tackled in the next couple of years. So we are really excited.
And Kate, are there any other positive developments you'd like to mention?
Yes, absolutely. There are great initiatives and there are great aspects of diabetes care in Ireland, starting from LTI scheme, meaning that people with diabetes have all their medicines and treatments reimbursed, so they don't have to pay out of pocket. Another one is Retina Screen, which is a screening program for all people with diabetes. Once a year or once every 2 years, eyes are being checked to figure out if the complications are not being developed. Another one is the pregnancy care for people with gestational and pre-gestational diabetes. So there are many other good aspects, but these are three that I would like to highlight.
Okay. I mean, one thing you said there, and actually it struck me as we've talked, you clearly have a good working relationship together. I mean, it's great to see that, because that's what it's about, isn't it? The community and primary care working together to provide the best service and resources available to people.
Absolutely. And I think everyone is trying to keep the patient at the heart of what we're doing, working together. There has been a lot of investment by the HSE in diabetes services in the last number of years, and that certainly has improved services. And we are starting to see the beginning of improved outcomes in where we are auditing it. But there are gaps, and I suppose there's more to do. And also what I would say is one problem we certainly have recognised is we don't have sufficient healthcare professionals coming through the universities. So we have jobs, but it can be challenging to fill them. So We don't have enough doctors, nurses, dietitians, psychologists, podiatrists coming out of college. And that's something that needs to be addressed again at a national level. So some of those things, we need a longer term plan to address those. And that's hopefully one of the things that will come out of the diabetes services strategy.
That's great. I would like to thank Dr. Kate Gajewska and Dr. Cathy Breen for joining me today. To all our listeners, thank you for your continued support and please share this episode. If you'd like more information about HSE Health and Wellbeing, follow us on X or take a look at our HSE Health and Wellbeing YouTube channel or register for our e-zine by emailing healthandwellbeing.communications@hse.ie. This has been the HSE Talking Health and Wellbeing podcast. Thank you for listening.